Hello, everyone. Yeah, I hope you can hear me okay. Thank you for joining us today for Focus Bites webinar. My name is Daria, and I'm the Global Learning Program Manager with Focus Certification Academy, and I will be your webinar host today. The webinar is now beginning, so all lines have been muted. Please use the Q&A box for any questions or the chat box for comments you have throughout the webinar. Today's topic is first trimester fetal biometry, and our speaker is Sabrina Starns. Sabrina graduated from Lone Star College Sci-Fair with an associate degree in diagnostic medical sonography in 2008. She obtained her bachelor's degree from Midwestern State University in 2018 with a focus on adult education. Sabrina is registered and proficient in multiple sonography specialties and most recently received a certificate in focus scanning from Focus Certification Academy. Her passion in education has driven her to work as a sonography instructor for the past 7 years in the Houston area. Her latest endeavor, Focus Med, is geared towards educating healthcare providers with cutting-edge technology to improve their patient care techniques and outcomes. Focus Med is also our official Focus education provider, and I just would like to welcome Sabrina today. Thank you so much for joining us. We're so excited to have you with us today and hear the presentation.
Thank you for the introduction, Daria. Hello, everybody, and thank you for joining us from wherever you are. As she said, my name is Sabrina. I'm the lead instructor at Focus Med. Although I'm a little nervous, I'm super excited to be presenting this material and super happy to be working alongside Focus Certification Academy in this educational activity. As mentioned, the topic for today's webinar is first trimester sonography. So I hope that you find this information helpful and beneficial to you in your practice. I used a couple of different visual aids for this. I used educational videos from the Butterfly Network with permission, of course. I also scanned an OB mannequin that I have for when I'm teaching this course live. And then I also scanned a pregnant friend in her first trimester. So if you have any questions at the end of the presentation, or if you want to review any of the videos or ask questions about those, please feel free to do so. I'll be happy to review them. So let me get started with the presentation.
Let's discuss the objectives for today's webinar. So what we're going to do is learn how to recognize the normal appearance of a gravid uterus or a pregnant uterus. We're going to learn how to identify and how to measure the gestational sac. We're going to learn how to identify and measure the yolk sac within the gestational sac, measure the embryo or fetus. You'll hear me use both terms because the baby is considered an embryo up to 10 weeks, and then beyond that is considered a fetus. So I try to use these words when it's appropriate, but every now and then I'll call it an embryo at the wrong week, but I do my best. But anyways, I use both of those because that's the technical term and people know them by both. So then we will obtain and measure the fetal heart rate using M mode or motion mode to confirm fetal viability. And then we're going to cover one abnormal, which is the most common reason for first trimester bleeding there at the end, which is the subchorionic hemorrhage. So I wanted to start by verifying that the first trimester is from 0 to 12 weeks of pregnancy. In a normal menstrual cycle, you'll count from the first day of the patient's last menstrual period. 14 days after that, ovulation should occur in a normal menstruating patient. If the ovum will be fertilized, that will be within 1 to 2 days after ovulation. And then implantation of the fertilized egg into the uterine wall is 12 days after fertilization. This is when the patient would typically be expecting menstrual flow. So sometimes if they have a little bit of implantation bleeding, they may either think that they have a period or have no idea that they were pregnant. The only reason that I'm pointing this out is to be sure that it isn't confused with subchorionic hemorrhage whenever we cover that later. And it shouldn't be confused because these are in different stages of pregnancy. You have to be a little further along to even have a chorion to have subchorionic hemorrhaging. So some people will use the gestational age for dating. They'll call it gestational age or the menstrual age. And it's dating the pregnancy with the first day of the last menstrual period as being the beginning of gestation. And that's how the majority of the packages that I've seen in the point of care ultrasound measure things is by the gestational age. So it's just good to know really what they're talking about. Some other measurements can be from conception, but you're still guessing that it was 14 days after the first day of the last menstrual period. So it's pretty much easier and pretty much universal to just go ahead and use the gestational age. A super helpful tool is being able to do blood work on the mother. So you can determine by their HCG levels in their blood how pregnant they are and what you would expect to see when you put the probe down. So if you are in an area where you can obtain this, it's good to know because if the patient, let's say their HCG is 500 milli-international units per milliliter, then you could possibly see the gestational sac or signs of pregnancy with transvaginal ultrasound because that's a much up closer view. And if your HCG level is 1800 or above, then you should be able to see some sign of pregnancy in the gestational sac transabdominally. This is definitely still going to be patient dependent on their size. It's also good to know the HCG level because you could have a really high one and then put the probe down and not see anything in the uterus. And then you have to be super suspicious of an ectopic pregnancy and go searching for that. So knowing the levels can be really helpful. Knowing if the patient's increasing, the levels are decreasing. That's all a little bit further along, but it's helpful. However, if you don't have access to this or it's not convenient, then definitely you can still do fetal viability and dating with ultrasound alone. That's no problem at all. This is just something additional that could help you out if it's available to you. For the major components, what we're going to be looking at whenever we evaluate the first trimester pregnancy is the uterus and adnexa. So we're looking for an IUP or an intrauterine pregnancy, or we're looking in the adnexa, which is like lateral. The space is lateral to the uterus where you might see your ovaries or iliac vessels. It's good to just see, like, is there anything out there? Is there a possible ectopic, or are there any masses on the uterus? It look like it might have any trouble delivering the baby later. You can just do a once over and just see if anything looks abnormal. Then you're going to look at the gestational sac. You're going to check the size, the shape, and the position in the uterus. You'll look at the yolk sac, which is inside the gestational sac and is the first thing that you see. You're going to look at the number of yolk sacs and the size of that. You're going to measure the crown rump length in the embryo or fetus to see the size for dating. And then you're going to measure the fetal heart rate with M mode or motion mode to confirm that this is a viable pregnancy. Okay, so before we get into the evaluation of the uterus, I just wanted to go over the anatomy of the pelvis in a still shot. So here we have a full bladder, and it's completely anechoic. The abdominal wall, because as I mentioned, this is a transabdominal scan. You have the vaginal canal. The CX is marking the cervix. LUS is marking the lower uterine segment. And then the fundus is marking the tip of the uterus. This is the endometrial canal. It's a little bit more hyperechoic in this image, and that is what is being measured. And then if we hop over to the image on the right side, once again, a transabdominal scan. We have the anechoic bladder here. We have the vaginal canal marked, the cervix, the hyperechoic endometrium that's wrapping around this gestational sac here. And as you see, the gestational sac is here in the fundus of the uterus. And then there's a fetal pole inside. This is a really helpful picture because as I go on to describe the placement of the gestational sac, I'll reiterate over and over how it needs to be in the fundus or the very tip, just as high up in the uterus as it can be. If it's in the lower uterine segment, the pregnancy can still be viable, but there's more risk of having the placenta cover the cervix or to have placenta previa, something to watch later in pregnancy. It's more common with the lower uterine segment placement. It's also just it can be a dangerous sign if your patient is having symptoms like cramping or bleeding, because then that could indicate that the baby was actually on the way out. So noticing that the placement of the gestational sac is important. Okay, so I will play you all a video. I'm going to play it from my computer because this screen is too small. Let's see, over here it is. So I use the butterfly and multiple different probes whenever I am teaching. And let me try to catch this before it starts playing.
Will often measure fetal heart rate using M.
It doesn't want to. There we go. Okay. And the reason that I show videos like this is if you have purchased an ultrasound machine, a point of care ultrasound machine, most likely it comes with a whole library of fantastic videos of how to scan, what to scan, normals, abnormals. So I encourage you to go through those whenever you do have a question. Okay. We're going to do the uterine scan through and what that looks like. This is a non-gravid uterus.
I'm going to show you how to scan the female pelvis using the butterfly. I'm going to start with my probe in the sagittal orientation with my probe marker towards the patient's head. And I'm going to use the bladder as a window to visualize the uterus and the long axis. So here we see bladder at the top, that dark anechoic area, and then just posterior to that, we see the long uterus. Here, I want to fan from left to right to scan all the way through the uterus. So I'm going to fan over to the patient's right and start to see her ovary pop into view there. Then I'm going to go back and scan through to the patient's left. And I'm using that fanning or tailing maneuver to do that. So once I scanned all the way through, in this view, the long axis on the uterus, you can also see the endometrium lining really well. So this is a great view if you wanted to measure that. You can also focus more inferiorly to the patient's cervix. And once you've gotten all of those in view, I'm going to turn my probe to the transverse view and then fan up to the patient's fundus. And then just do a sweep from fundus to cervix. Fanning down. Okay, once we've done that, I'm going to look for the patient's.
We're going to stop her there. So that's just kind of showing how to do the sweep of the uterus in both the sagittal and transverse plane. And we'll go back to the PowerPoint. All right, so it's not a requirement for you to do measurements of the uterus, but it is common in first trimester sonography exams, so I just briefly touch on it. If you are going to measure the uterus, pregnant or not, you're just going to lengthen it out as much as possible. Some patients' uterus can kind of lean to the right or kind of angle towards the left. So you'll do some fishtailing to make sure you have the full length of the uterus, and then you'll apply calipers. So in your sagittal view, you see you have a nice bladder here. That's definitely helpful in really early pregnancy. to see the gestational sac. It's not necessarily required, but if you have a patient with larger body habitus, it's helpful. And then if it's not helpful to you, just have the patient void and then image again. It can't hurt. One thing the bladder is helpful for whenever you're new to scanning is knowing that you're scanning low enough on the patient's body to get to the uterus. So it can be helpful there. But anyways, in the sagittal plane, you'll go ahead and do the length, the full length of the uterus, and then the height. And then in the transverse plane, once again, bladder's in the image here. You're going to go to the widest part of the uterus or the fundus. You should have endometrial tissue in there, and you'll put your calipers in transverse to get the width of the uterus. That's moving right along. All right, so after evaluation of the uterus and the adnexa, just making sure everything looks good from the top and kind of like a global view, then you can focus in on the gestational sac. At the 4th or 5th week of embryonic development, the gestational sac will have a hyperechoic or very bright tissue surrounding it. This is called the double decidual sign. The decidual wall thickness should be 3 millimeters or greater. And once again, when evaluating the gestational sac, you're going to be looking to make sure it's round or oval in shape. This is a first trimester mannequin that I have that I use in teaching. And as you can see, she also has the double decidual sign or the bright hyperechoic border. This is the imitation uterus here. This line is the imitation cervix. This is the imitation bladder. And then the imitation gestational sac that you see is measuring here. So you're going to want to look at the gestational sac, make sure it's round or oval, that it's in the fundal position or in the tip, the highest in the uterus that it can get. A lot of times the yolk sac is seen there, and it's the first structure seen as early as 5 weeks. We'll move into that in the next couple of slides. The gestational sac will remain accurate in measurement up to 8 weeks. So after 8 weeks, it's no longer an accurate measurement. It's really just used when the fetus is too small to see and you're trying to figure out how far along your patient is. You're going to go ahead and get these 3 measurements. So of note, the smooth walls here, the smooth border of the gestational sac, if you're having jagged or ill-defined borders, that would be a sign that the pregnancy may be in jeopardy. So the mean sac diameter, or getting the 3 gestational sac measurements, you can put them in the in your package from the machine, and it will go ahead and get the mean sac diameter for you, and will calculate the gestational age based on that. What you want to be sure of is that you put your calipers at the fluid tissue interface, measure only gestational sac fluid, excluding the echogenic decidua. So my caliper stops right where the black and the white meet here, or the anechoic and the hyperechoic in ultrasound terms. So do not include the wall. You'll take the length and the height of the sac in the sagittal plane. You may have to tweak your probe just a little bit to make sure you get the full length of the sac, and then the width of the transverse view. So I believe I did the video of this on the mannequin just to show you how to like plug it into the package and what it looks like when you're doing that. And I think you can see you do have to select what measurement you're going for with this particular probe, and that's pretty common. But you can see I was angling around to make sure I got the full length. I'm placing my caliper at the border of the wall, measuring the fluid only and not the wall. And I am using my package. It's gestational sac diameter 1, 2, 3. If you don't get this right, the measurements will be off. But you know, there's always deleting measurements and re-entering, you know, which diameter you messed up. It's completely normal. Here I am going in the transverse, trying to get a nice round image that's uniform, that I could put my calipers straight across to add the width of the gestational sac. to the mean sac diameter. And once I confirm that with an image, I'll go and look at the report. And as you can see on the top, it says MSD for mean sac diameter and then gestational age, and we're measuring at 8 weeks. And then that will also, by the mean sac diameter, give you the estimated due date. But remember, since we're at 8 weeks, this is technically the last time that we can measure this gestational sac and consider it accurate for fetal dating. Let's see. So now we'll move on to the yolk sac, which, as mentioned, is the first structure visualized after the gestational sac in early pregnancy. So that's that bright little circle inside there. The normal measurement should not exceed 6 millimeters. The yolk sac is important because it confirms a viable pregnancy in 90% of cases. So if you put the probe down, you see a gestational sac that's measuring, say what we just measured, like 8 weeks, and there's no sign of a yolk sac inside, most likely that pregnancy will not progress. I believe the technical term for that is a blighted ovum. What we're seeing here too is that the yolk sac should be perfectly round, just like the gestational sac. You don't want to have jagged or ill-defined borders. And just like the gestational sac, when you're doing your measurement, you're going to make sure that you're not going to include the walls of the yolk sac in your measurement. And as mentioned, it shouldn't go beyond 6 millimeters. The other cool thing about the yolk sac is it's connected to the embryo via a stalk. And what it's doing is it's basically taking the place of the placenta and providing for the embryo before the placenta takes over. So it is performing the essential functions in embryonic development. It provides nutrients to the developing embryo. It assists in the production of blood cells, platelets, aids in development of embryonic arteries, veins. It forms the primitive gut. It is super important that it attaches to the fetal pole here. That's what meant by FP. This tiny piece of the echogenic tissue is actually the fetal pole really early in pregnancy. And without the yolk sac, it would be so difficult to find that in there. So that's one reason sonographers or anybody performing ultrasound exams is super grateful for the yolk sac. As the amniotic cavity expands, the yolk sac will detach from the stalk at 8 weeks, and it will eventually go away when the amnion fuses with the chorion later in pregnancy. We'll cover that a little bit further along too. The next thing what we're going to cover is the crown rump length, so literally measuring the embryo or the fetus, depending how far along we're on. Once again here, we see the gestational sac, the anechoic gestational sac, the hyperechoic yolk sac, and then the fetal pole here being measured. You're going to measure from the top of the head to the outer fetal rump. You will exclude the limbs. And this is the most accurate for determining fetal age up to 12 weeks. So the first trimester alone. Beyond the 12 weeks, the fetus will begin to curl and the measurement will be off. So just as a reminder, the gestational sac was accurate in measurement up to 8 weeks and was the first thing seen and easiest to measure for dating when the fetal pole is tiny. But whenever you can get a hold of the fetal pole, you can see it attached to the yolk sac, and you start measuring that. That is the most accurate form of fetal dating up to 12 weeks. Let's see. If you had asked the patient their last menstrual period, the first day of their last menstrual period, you could put that in your measurement package for your POCUS point-of-care ultrasound machine. sometimes it's accurate and it matches correctly, but sometimes it's not, because either the patient forgot when the first day of their last menstrual period was, or they're dealing with PCOS, like polycystic ovarian syndrome, and they don't ovulate normally, or they don't have normal menstrual flow. So either they didn't have a period or they had too many periods. So when you're kind of up against, do I go with the last menstrual period, or do I go with my crown rump length? Definitely you're going to go with the size of the embryo. Okay, let's see, moving on. All right, so here I am. I took a measurement of the crown rump length on my mannequin as well. What is recommended is to take at least 3 separate measurements of it. The reason that you do that is to, especially in the beginning, making sure that you've completely lengthened out the embryo. So sometimes it takes some like fanning or fishtailing, mostly fishtailing, just to make sure that you have the full embryo in shot before you put the calipers on. So let me go ahead and play this video. One thing of note is you can see I'm kind of like looking for the fetal tissue, looking for the best image, and then I zoom in on it because I'm like, okay, I really want to get these calipers right, and I'm not liking my image. So I zoom back out, and then I increase the overall gain to make the fetal tissue stand out better, to get that measurement. So then I selected the crown rump length measurement so that it will be put into my package and give me a gestational age. And then now I'm just trying to get my calipers to work with me to get a good CRL measurement. Once I confirm that with a picture, you can go to the report and see, or actually you can see it at the bottom there. It's measuring 7 weeks, 5 days. So once again, this is the most accurate form of measurement up to 12 weeks for fetal dating. Now, the fetal heart rate, we're confirming viability. One thing to know that's helpful is if you can measure a crown rump length that's 7 millimeters, you should see cardiac activity at this point. What you would do if you measure, let's say, the crown rump length at 9 millimeters and you don't see cardiac activity, that is still a super small embryo. So the recommendation is to return a week later and attempt to find the cardiac motion. You're going to use M mode to get the image of the cardiac motion over time so that we can measure it. One thing to note in the first trimester pregnancy is to use the M mode only, not to use the pulsed wave or the color Doppler, just to avoid any potential bioeffects that we're not aware of at this point. The pulsed wave Doppler is the one where you can put the cursor over the fetal heart motion and actually hear it. So one thing, I'm going to go ahead and play this one also from the file, so it'll be a little bit bigger. This is the use of M mode scanning for the fetal heart rate.
In early pregnancy, we'll often measure fetal heart rate using M mode. So we're going to demonstrate how to do that with butterfly.
Okay, we are in the OB1 GYN preset, placing the butterfly on the skin and locating the gestational sac.
All right, and we've got gestational sac in the center of the screen. You can see yolk sac on the right, fetal pole in the center.
And I'm just fanning through here to locate the motion of the heart.
And double tapping there just to zoom in, and we can see fetal heart motion right in the center of the screen. So from there we'll use M mode by going to the Actions tab and activating M mode. And we can reposition the M mode cursor or spike as needed to intersect the fetal heart motion. And then we're seeing periodic repetitive signal on the screen representing fetal heart motion over time.
Freezing this image, I can then go to my measurements, select the calipers, and measure 1 cycle.
And we have our heart rate displayed on the screen automatically, and that's how you measure fetal heart rate using Butterfly.
That screen was a little bit difficult to see, so I did add an image that has better description of what's going on here. So when you turn M mode on, the cursor will drop into the image. You're going to put it directly over the fetal cardiac motion. And then when you activate the M mode, it will give you a picture. And these are very small here, but there are blips. Okay, whoops. There are, you can look at the fetal heart rate and watch to make sure that you agree that these match. The thing about measuring is you're going to use your usual caliper, but the rule of thumb is to be sure that if you put your caliper at the beginning of one heartbeat, then you're going to put the second caliper at the beginning of the next heartbeat. Or for instance, if you put the first caliper at the end of a heartbeat, make sure that the very next one you put the caliper at the end. Wherever you put the caliper is your decision. Just make sure that you do it exactly the same on the next heartbeat to get an accurate measurement. The fetal heart rate averages at 6 weeks. It's typically between 90 and 115 beats per minute. As mentioned before, at 6 weeks, sometimes it can be very difficult to visualize. Once again, if you don't see it right at 6 weeks, maybe it's due to the patient's body habitus, then check again at the 7th week or the 7.5 week before making any determinations or jumping to any conclusions. And then for 9 weeks, the fetal heart rate should be 140 to 160 beats per minute. And then the remainder of the late first and second trimester is 140 beats per minute. So anything below 90 beats per minute at any age would give the pregnancy a poor prognosis. Another structure that you may see when imaging your first trimester pregnancy is the amnion. So here we have the anechoic gestational sac, the hyperechoic yolk sac, the echogenic embryo, and then this thin line that you can see around it is the amnion. The fetus sits in the amniotic cavity in amniotic fluid. And it can be visualized before the 12th week of gestation. It's just this thin membrane. If you have a multiples pregnancy, you can see multiple yolk sacs, multiple embryos. It's good to determine at this point if the babies are in the same amniotic sac or if they have their own, because it's pretty much too difficult to do beyond the first trimester. The chorion lines the gestational sac. Sometimes you can see a bright reflective layer here. The point of that is the amnion and chorion will fuse at 14 weeks. And the yolk sac will go away at the time as well. You'll no longer see that amniotic band. Okay, and then the most common reason for bleeding in the first trimester, we're going to go ahead and cover that abnormality. So a subchorionic hemorrhage will occur when there's bleeding that collects between the uterine wall and the chorionic membrane in pregnancy. So a lot of patients are seen for this in the ER during their first trimester. As I mentioned before, not to be confused with implantation bleeding. As you can see how far the baby is along here, we are much further than just 30 days into this pregnancy. So you will not confuse these two. If your patient does come in with bleeding, it's important to document how much blood is present, if clotting is present, the size of the clots, the duration of bleeding, if it's getting any better or any worse, if there's any associated pelvic pain or cramping. That will prepare you for what you might see during your exam. So say you have a patient that just has a little bit of light bleeding, some small clots, but is just really concerned, you'll see possibly a subchorionic hemorrhage here. So the pink arrow is pointing to the anechoic area right there adjacent to the gestational sac. You'll just go ahead and scan through the uterus all around the gestational sac and the sagittal and transverse plane to see if you can see this subchorionic hemorrhage. If you can, it can look anything like pretty anechoic like the gestational sac, or it could have some debris within, like you can see in this image. Or as it continues to clot, it becomes more echogenic and can almost match the echogenicity of the uterus. It'd be kind of difficult to find. But you can scan these, just make sure and lengthen them out. I mean, you can measure these if you want to do serial scans to see if they're resolving or getting worse. There's plenty of reasons that a subchorionic hemorrhage happens. Sometimes it's completely unknown. Sometimes it's due to trauma. There's a bunch of different reasons, but usually they resolve on their own. They're not as threatening as they are just very scary for the patient. The other thing about asking your patient their symptoms is because, if they're having like light spotting, some clots, not cramping or pain, sure, okay, you're probably going to see a subchorionic hemorrhage. If you have a patient that is complaining of pain, cramping, has passed a large clot or multiple large clots, then you might want to be curious or prepare yourself to consider that maybe a miscarriage has already happened. Either way, that doesn't really affect your interaction with your patient. It just prepares you for what you might see when you put the probe down. And just to reiterate, the subchorionic hemorrhage is the most common cause of bleeding in the first trimester. That's why I decided to cover that one. You should be able to confirm fetal viability with your gestational sac, the appearance of it, the measurements of it, if it's up to 8 weeks, the crown rump length, the measurements, in your serial scans, you'll be able to tell that it is growing as it should, matching the gestational age, and then of course the fetal heart rate. And that will complete the first trimester sonography.
Thank you so much, Sabrina, for this wonderful presentation. I encourage you guys to submit any questions to Sabrina, but before we go into the Q&A part, we have some quizzes for you, and let's see and check your knowledge on what you just hear. Okay, first question is, embryos with heart rates below beats per minute generally have a poor prognosis. We have 90, 100, 105, and 110. I'll give about a minute to everyone to respond. We have about 42 people from whoever is watching responded, so we'll give another 20 seconds. All right, 10 seconds. And I'm gonna end the poll and see the results. All right, Sabrina, do you want to comment on the responses?
I'm not seeing the responses. Hold on.
Okay, so we have 84% answered 90, 8% answered 100, and 7% answered 110.
Okay, so the majority of everybody got it right. The heartbeat below 90 in any trimester is indicative of a possible poor outcome. Of all the heart rates that were mentioned, all the averages, 90 was the lowest, and nothing at 6 weeks. So nothing should go below there. It should never be below 90. So the majority of you guys got it right. Good job.
Perfect. All right, let's move on to the second question. And all right, the crown rump length measurement may be used up to the gestational week, 10th, 11th, 12th, or 13th. All right, there's some good participation. We're at 50%, whoever's watching. So let's give it another 15 seconds. Okay. Almost there. So I'm gonna end the poll and share the results. All right. The correct answer is 12. So we have tenths, 8% answered 10th, 6% people answered 11th, 72% answered 12th, and then 14 answered 13th. So Sabrina, you want to comment on that?
So an easy way to remember this is just, you know, the first trimester being the first 3 months, that's 0 to 12 weeks. So the crown rump length is appropriate for the first trimester only. The reasoning behind that is that after the 12th week, the baby will begin to like curl into the fetal position. So then your measurement from the crown to the rump can turn out to be smaller, as if the baby is getting smaller in size, which would be inaccurate.
All right, and one more question before we move to Q&A. All right, the most common cause of vaginal bleeding in the first trimester is which one of the following? All right, we have people just jumping in and answering. I like that. Maybe next time I'll play some music here. So we have about 60% people who answered. So I'll give another 20 seconds. All right, we're at 65%. So 10 more seconds for you guys, but I have a feeling this one is pretty easy for me. All right, let's share the results. And we have 96% answer subchorionic hemorrhage, 2% answered ectopic pregnancy, and then 2% answered missed abortion.
The majority of those got it right. I'm trying to see that. I'm trying to think about the difference here between the. Yeah, I feel like the majority of you guys got it right. That's just going to be a bleeding or a hematoma below the subchorionic layer where the fetus is actually attaching to the uterus.
Great. Thank you so much, everyone, for participating. And let's move to our question and answer. We have a person asking how to measure cervix and is insignificant to measure CX in the first trimester.
Yeah, so I think that's a really good question. And the significance of the cervical length is way more appropriate later. So basically your cervical length needs to be 3 centimeters or longer for it to have integrity. And when it's shorter than that, your doctor, the doctor or whoever's scanning will do serial follow-ups on that to make sure that it doesn't open and then accidentally lose the baby too soon or have the baby too soon. It's not as important in the first trimester. They don't do a measurement because, as we saw in those pictures, like when the gestational sac is very fundal in the uterus and you can see endometrial tissue all the way down that follows it to the cervix. If there's cervical insufficiency, it's just open. Like you would definitely have a miscarriage there. There's no saving it there. So cervical measurements are more important in the second and third trimester to make sure they're above 3 centimeters.
Okay, thank you so much. We had someone asking, will this presentation be viewable again? Yes, this is recorded and we'll be posting it on our website, and you will also receive a link in about a week to watch it again if you miss anything. Moving on to the next question, is CX length also included in the first trimester scan?
That's the same question. Yeah.
Yep, we just covered it. So, next one is, what is the difference between subchorionic and subamniotic bleed? Is there any clinical significance?
In my experience, the subchorionic hemorrhage is more of an issue in the first trimester whenever there's all this angiogenesis going on and all this new growth inside the uterus. The subchorionic hemorrhage is just a common issue there. The subamniotic would be probably something that would be seen later on in pregnancy. I did look this up because I saw that in the question, and the information that I found says that a subamniotic hematoma is defined as a hemorrhage between the amniotic membrane and the fetal chorionic plate following damage to one of the branches of the umbilical vessel. In this case, it would be in a different area. It would be below the amnion and not the chorion. The chorion's that super bright tissue. You would see it in between the super bright tissue and the amniotic sac, which is already fused with the chorion at that time. So I think that that would be a much more difficult image to capture, and also something seen later in pregnancy. I don't have a lot of experience with that, with a subamniotic hemorrhage.
Okay. Thank you, Sabrina. Do you have any comments on the twin pregnancy?
Like what I covered for first trimester was what you really are trying to figure out, especially in the first trimester, is do they have their own amniotic sac and do they have their own chorion? You can determine that by one of the ways that I mentioned was looking for that amniotic band. Is there one in between the babies or not? There is a lot more information on that as far as having their own placenta and things like that, that I would just encourage research on, probably to familiarize yourself with that.
We have a person asking, can you go over the M mode measurement for FHHR, please? Could not really see the movement.
Okay, so let me pause my screen sharing and get to that image again so that I can point at it. Give me just 1 second.
Yeah.
Or actually, I'm not sharing screen.
Yeah,
right?
you'll just have to reshare, Sabrina.
Okay, let me get that. Give me just a second to get that image up, and then we can look at it together. I'm not sure if there's any other questions I could answer while I'm looking at this.
Sure, I can go over.
If there is one.
On CRL, what's a cutoff point?
Just the very tip. It said, what's the caudal point?
Cutoff.
Oh, the cutoff. Well, like when, oh, like that you can only measure it up to 12 weeks. Is that the question?
Philip, if you want to type a little bit more information on what you meant by that, feel free.
The crown rump length measurement, the cutoff is at 12 weeks because it's no longer considered accurate after that, because the fetus will begin to curl into the fetal position. So that's the measurement.
I'm gonna allow to talk for Philip so he can explain a little bit. Give me 1 second. Hi, Philip, go ahead.
Hello.
Hello,
Hi.
Philip, go ahead.
Can you hear me? Yeah, it's just a follow-up question to the second question on the quiz. Because when I responded at 12 weeks, are you getting me?
Yes, we can hear you. Go ahead.
Yeah, when I responded 12 weeks, I was marked as wrong answer. So I'm trying to figure out where am I getting it wrong. That's why I had that follow-up question. I wanted to understand exactly what's the cutoff point.
I don't think I understood the question. I'm sorry, Philip. You were not sure why you weren't getting the correct measurement. Is that what you said?
I'm saying it's a follow-up question to the quiz question number 2.
Uh-huh.
Whereby you were asking at what point do we measure C crown rump length? So when I answered at 12 weeks,
Uh-huh.
It marked me wrong. So that one gave me a headache to say, according to the explanation of Sabrina, is at 12 weeks, and now I'm getting 12 weeks as the wrong answer. So I wanted to understand from you, is it at 12 weeks or at 11th week?
The answer correct is at 12 weeks. If
Thank you so much.
Yeah.
It was the answer. Yes, it was the answer. Thank you. All right.
Okay, I do have the image up, and let me go ahead and bring that up. Is this a little bit bigger?
Yes.
Okay, so let me just go over this picture together, like some more helpful information. Can you guys see my pointer?
Okay.
You can, Daria? Okay, so something that's interesting about M mode, you see how, we do have an image of like the uterus, the gestational sac, the fetal pole. We turn M mode on and we get this cursor, and every machine's different, but a lot of them, you just move the cursor over to where you see the most fetal heart motion, because that's going to give you your best image of motion over time so that you can measure it. So right here, even though it's a still shot, this is most likely where the fetal heart rate was doing the most amount of movement. And then when we activate M mode, then we get a picture of this movement, right? And something that's super helpful is to know that the depth of this image directly relates to the depth of the M mode picture. So where you see that we're going through uterine tissue here, that matches here where you see some echogenicity. Where you see that you're going through anechoic gestational or amniotic fluid here, matches the anechoic part of this image here. And then right where the cursor would be going through the fetal heart rate, that's where you're going to be looking for those blips. And I know that these are still small, but hopefully you can see those. So you're going to get this M mode, and you're going to know where to look on the image for these heartbeats, because you can see other motion up here and things like that. If you move your hand while you're holding the probe, that's going to be picked up on this as well. So this is a little bit difficult because you need to be holding your hand very still. That's obtaining the fetal heart rate, and then looking at this image to make sure it's right. If you don't like the way these beats look, get another image, because you need an accurate fetal heart rate. What I mentioned on my slide that I think your question is about, or the very important part of measuring here, is that if you pick, let's use one of these over here. So see how we have 1, 2, 3, 4 beats like this. Whoever's giving the thumbs up, thank you. That's very encouraging. I appreciate it. Whatever you do here, 1, 2, 3, 4, you can see these beats. Whenever you put your caliper on it, say you put your caliper right here at the beginning of this beat, put your caliper at the very beginning of the second beat, because that's going to give you an accurate measurement. If you decide to put your caliper at the end of this beat, make sure you put your caliper at the end of the next beat. So wherever you choose to measure, make sure it's exactly consistent. Where on one beat, make sure it's exactly consistent on the next beat to make sure that you get an accurate reading. And I hope that answered your question. If it didn't, please, type again, because I do want to cover that well.
Great. Thank you so much, Sabrina. I see a lot of people are just chatting away in the Q&A. If you want to continue your chat, feel free to use chat box, and we'll just find more questions in this area. So Another question is how to diagnose placenta preavia in its first trimester.
So you really cannot diagnose that. These are excellent questions, guys. So you can't diagnose that in the first trimester. The placenta is developing, and you will be able to see where, if you're going to get an anterior placenta, a posterior, a bundle, you will be able to see where the placenta is going to develop, create itself in the gestational sac. But as the fetus grows and the uterus grows and stretches and grows up larger, the placenta goes with it. So placental evaluation, you're going to start it, in the second trimester. As soon as you can see it, you're always imaging it and looking at it, making sure it looks healthy, making sure that the umbilical cord is inserted in the correct place. But at the same time, you're going to be measuring the tip of the placenta. And as the baby grows, and gets larger, it really should move up away from that internal cervical os. And so in the third trimester, you still can watch and measure it. Things can still kind of creep up a little bit higher, but you'll know if it's close. So I believe it's within 2 centimeters is whenever it's like a creta, or like whenever it's a little bit dangerous, that even if the placenta isn't over the opening, the vessels may be. So that's going to be something that's seen in serial scans and watched if the placenta is close to the cervix.
Thank you so much. Just going through some of the questions here. Can subchorionic hematoma help in predicting poor outcomes in pregnancy?
I've imaged a lot of these in my day. I can't say that I've followed up with every single patient to see what happens. Definitely the size of the subchorionic hemorrhage is important. But also the health of the baby, how the baby's imaging anyways. Is it measuring according to age? Does it have a good fetal heart rate? Those things are all factors in it. The majority of cases, the subchorionic hemorrhage resolves on its own. I wouldn't put my probe down and look at that and tell the mom that she needs to worry. I would say, let's check it again in a couple of weeks and make sure that that it's not getting larger. I have seen patients be put on bed rest if it is, something's going on traumatic that needs to be calmed down. But I wouldn't say it's a super risky find, whereas a low heart rate or a low implantation in the uterus would be more worrisome.
Okay, thank you. I think we have for one more. Last question would be, if there is no heartbeat found at the crown rump length 7 millimeters or greater, can you diagnose fetal demise? Thank you.
No. So I think I covered that in the PowerPoint because I didn't want people to take that way. So what the information says is that at 7 millimeters, at the crown rump length being 7 millimeters, a heart rate should be present. Say you have a very large patient and the ultrasound machine that you're using doesn't penetrate well into the patient's abdomen. And so you can get a pretty good picture, some pretty good echogenicity to measure this baby and confirm that, yes, it's 7 millimeters. But the capability of the ultrasound machine that you're using may not just be that have that type of definition available. So what you do is at that age, you would still measure the gestational sac to make sure that matches. Ask your patient if they're having any symptoms. Definitely not a reason for concern. What the recommendation is to have the patient come back in a week and rescan for fetal heart tones. At that time, you'll also be able to confirm, is the fetus still developing? If there were no heart tones, if that was a true finding at 7 millimeters, the fetus will still be 7 millimeters or smaller.
Okay, thank you so much, Sabrina. I know we have a couple of more questions, but we can follow up probably with your questions via email. And I just wanted to thank Sabrina for joining us today. I'm going to launch one more poll for you guys to see if you will be able to apply what you learned from the session to your specific job, overall career, professional, personal development. And again, thank you so much, everyone, for joining us today. And thank you for your questions. And thank you, Sabrina, for this great presentation. We hope to see you again next time.
Yeah, I also wanted to thank everybody for joining and listening. I also wanted to encourage everybody to take advantage of the certifications that are offered by PCA, the POCUS Certification Academy. As myself, as a registered healthcare provider, and I'm sure the same with you guys, you understand the importance of becoming certified in whatever it is that you're practicing to help move the field along, advance it, continuing the education. So that being said, that's what I want to encourage you all to do. Of course, if you need help with education, please feel free to reach out to me. But also, if you don't mind connecting with me on LinkedIn and on Facebook, I'm trying to work on closing any gaps in between education and certification and getting people proficient. So I'm looking into adding educational tools to either the LinkedIn page or the Facebook page. So if you'd like to connect and be a part of that community, please feel free to do so. And email me with any questions that I wasn't able to answer today.
Awesome. Thank you so much. Again, everyone, we'll see you in our next webinar next month in February. And feel free to email us with any questions. And again, we'll follow up with the question that we were not able to answer today via email. Thank you again, Sabrina, and have a wonderful day. Thank you, everyone.
Thank you, guys.
Have a wonderful day. Thank you.